All right, is anybody, Greg, do we know if anyone's on the phone this morning?
Hi, it's Sid Gottlieb.
Hey, Sid. And hi, Betsy.
Scott Inner's on the phone as well. I'm driving in.
Hi, Scott. Thank you.
Betsy Carrier's on the phone.
Hi, Betsy.
Hi.
Okay, maybe as usual for housekeeping, we'll start by just going around and doing a roll call. So we'll start with Barry.
Barry Rosen, a lawyer from Gordon Fondlett.
Hi, I'm Shannon Isaac. I'm from the University of Maryland Medical Center and the University of Maryland School of Nursing.
Orly Panich, emergency physician with MEB.
Ben Lowentred, a urologist with Chesapeake Urology.
Private practice, Montgomery County. Vinu Ganti, private practice in Montgomery County. Thank you.
Thank you.
Kim Repack, Western Maryland Health System.
Good morning, David Sharp with the Maryland Healthcare Commission.
Laura Herrera, DHMH.
Good morning, Charlie Royland, Johns Hopkins Bayview and Johns Hopkins Medicine.
Nicole Stallings, Maryland Hospital Association.
Okay, good. Okay, so I circulated yesterday, and hopefully you all have, well, you all have because it was put on the table, a PowerPoint that we'll use to just guide the discussion today. As we said last time, today's meeting and the next meeting are really just for discussion. You know, we've had a lot of experts, but now it's the time for us to sit and talk and work towards the recommendations that we have to produce. So we'll start. This PowerPoint is just meant to guide the discussion, but hopefully it'll be a pretty interactive session today, talking about what our recommendations will look like. I actually want to start at the very beginning by just talking about something that a number of us have talked about in terms of where we might land, because there's a lot of details to talk through today, and I just thought it would be helpful to start with what could be a possible answer. And the possible answer is to use ACOs have, and if anybody who's helped talk about this, feel free to jump in. ACOs have, there's CMS put out authority to give a bunch of waivers to ACOs to enable gain sharing, or I should say shared savings more broadly, so population health and non-hospital dollars. And there's a whole series of laws to which those waivers apply, which enables it. And in that document where CMS provides the waiver authority to ACOs, it specifically says that those same set of waivers can be applied to other CMMI demos, of which we are one. And the goals of the Maryland system are identical to the goals, to the population health goals of ACOs. So it's very consistent to say that same set of waivers from Stark and anti-referral, and specifically the distribution of shared savings is one of the specific of the 5 waivers provided for. That would give us the basis to be able to do what we want to do is one way. And I think if you get that, then underneath of that authority, you can do distributions based on a number of mechanisms, whether it's pay-for-performance mechanisms that in theory you can do without approval, but at least then you'd sort of know and you'd have this broad authority, whether you want to do it on a per case within the walls of the hospital, whether you want it to be bundled payments, or whether you want it to go all the way to population health mechanisms. You could do a full range of options underneath that broad set of waivers. So I just want to throw that out there as a possible approach we could take with CMS, which would give us a full range of options. So, and it seems to be consistent with the law. It seems like you'd be handing CMS a good answer because they've already created this, and it seems to work for us. So anyway, so that why don't I stop there and see if I think some people we've talked about this. If anyone else has any thoughts about that. Okay, Barry, I mean, it's just as someone that's probably familiar with that authority, we didn't have a chance to talk. So.
I think it's a fine idea, and it's at least a nice starting point, because the opposite of trying to craft and say we want to do X goes against MHA's recommendations about mandates and flexibility, giving the hospitals flexibility. The opposite is saying we want to do this particular program. Can we have permission for it? Then you are going back program by program. It'd be nicer to get it blanket.
Yep.
A caution, CMS has also been concerned about paying twice for the same thing. And you may get that kind of a pushback saying, yeah, okay, but not if you're in another ACO. I'm not saying that CMS response is correct, but they seem to be worrying about people gaming the system and CMS paying an ACO for bringing the cost down and CMS paying other people to bring the same cost down, and they pay twice. So there may be a pushback because of that. But as a principle, I think it's a better strategy than us crafting a specific program and saying, can you bless it?
Yeah, no, that's great. And I could see where they could say, you got people in ACOs, you got people in Medicare Advantage. You can use this structure for everybody else. I think that would be a perfectly reasonable response to not want to pay twice for people that are already in an ACO. This would give us flexibility because those ACOs, the point is, those ACOs already have the flexibility to do the spectrum of shared savings activities because they have that waiver authority, so they can do it. What we're trying to do is create the ability to do that same thing for the Medicare fee-for-service patients where that authority doesn't already exist. So I think that's consistent. Okay, good. So I guess with that, I just thought it would be helpful since some of us have talked about that. The PowerPoint, we got a lot of details here. I always think it's good if someone has a picture where you're trying to land before you get into the details. Maybe it also, helps people. It's a little easier to pay attention when you know where you're going. So, with that said, why don't we just jump right into this PowerPoint? I think we can talk through it section by section. Feel free to, hopefully it'll be an open discussion. So just starting on page 2, we have a report due at the end of, we need to finish at the end of May. Oh, thanks, Ray. We need to finish at the end of May. Our report's due to the commissioners at their June meeting on the 11th. Want to send it to the commissioners a week in advance whenever their packages go out. I'll actually skip down to the bottom of the page and then work back up to the report outline just to talk about process. We initially had a meeting for later in May. I think it was the 22nd, but we moved it to May the 6th. I think that's a good thing, just as we're trying to work towards creating a report. It gives us time between today and May the 6th. The goal of today is to talk about it enough so that we can actually write a draft report and get it out to all you guys at least a week before the May the 6th meeting so that on May the 6th we can really step through it, through the draft. And then that leaves plenty of time to incorporate comments after May the 6th, get it back out to you. We may not have another face-to-face meeting plan, but there's plenty of time to talk offline, by email, to make sure all your suggestions from May the 6th get incorporated to finish up by May the 30th. So in terms of process, that's where we're going. And I encourage people between now and the May the 6th meeting, while we'll create a draft report and get it out to you a week in advance, happy to talk offline as we're moving through the process. stepping back up on page 2 and a proposed report outline. We show it here, the sections. Not sure we have to talk through them, but that's sort of the structure for a report. So maybe before we go on to the next page, we can stop there and just see if anyone has any questions or suggestions related to the process we've laid forth between now and where we're trying to get to at the end of May, as well as the proposed report outline.
I was just going to ask, have we seen the advisory council recommendation?
That's a good suggestion, and we get to that on the very next page. You're right. We're probably putting something here that you hadn't seen. So send out. That's a good suggestion, Lars, to send advisory council report to all. Lars, question. If you don't get exactly what the question's getting at, you will in just a second as we get on to the next page. But that's a good suggestion. So thank you.
And in the meantime, it is on the website, so you're welcome to view it on the website, but we'll get it to you.
One question. So there will be one report that will have payment models and recommendations around gain sharing, pay for performance, shared savings, or is it two separate? I'm just looking at the work plan, and it looks like 2 deliverables versus 1, but maybe.
Yeah, that's also a good question. Whether we'll do it as 2 separate reports or 1 report, I'm not sure. As I was sitting here this morning, I was thinking more about the gain sharing / shared savings report. But you're right. We also, as I've said before at other meetings, we need to do the report on the overview of current payment models, and that's also one that we'll need. We'll appreciate input on, since we don't have a complete vision of that which is going on with payments.
So I have a question about the granularity of the recommendations. Can you provide any guidance on what your thinking is around how deep we should be formulating these recommendations?
Sure. David, I'm sorry. Were you here when we just got started a few minutes ago? So you heard the discussion about leveraging the ACO
right, but
authority.
We could talk about it as a concept,
yeah.
Or we could talk about it more specifically that hospitals more along the lines shall do. So that's where I was trying to understand where you're thinking of as a balance.
So we'll talk about that, and that may be a good time to, actually, I want to hand out something that Nicole Stallings sent to me. I mean, this gets into the principles, but as long as you've asked that question, I didn't even want to remember to send this around. So just take one and send them around. Because I think, David, Nicole, I think that question kind of gets into principles. Sort of whether it's voluntary or mandatory. I think part of the answer to your question, David, is we're trying to create broad flexibility, but I don't think we want to tell people. We'll get into this today, but I don't think we want to tell people exactly what to do. I think we want to give them the ability to do.
Okay. Is it helpful, though, if we drew maybe an example or two where you say we're articulating principles and these are just the examples of the kinds of things we could see happening? I'm not really sure the people who are going to read this and act on it, how much they've thought about this. And so if you speak in principles and don't give people one or two granular ideas about what you mean, it may not be as helpful.
Completely agree. And as we move through this today, as we get to page 6, I'd like to think that'll facilitate a discussion around specific granular examples and the need to identify low-hanging fruit and specific areas, and that different clinical situations demand different models, whether it's a population health model or a bundled payments model or a case-based model. Whether you're trying to prevent admissions for people with CHF to whether you're trying to control the cost of a admission within the walls of a hospital, whether you're trying to control an episode. I think we should. I do envision us giving examples of all, because I think that will show, and I think we need to with CMS, because I think that will say why we need this broad authority, is because different clinical situations have different need to share savings with different types of providers to provide the incentive to control certain behaviors. So yeah, I think we'll get into specific clinical examples of each. Any other questions related to page 2 before we go on to page 3? Yeah, I don't think there's a lot on page 2. It was really just housekeeping in terms of process. On page 3, and this is a question Laura was getting at a minute ago, part of what we want to make sure we do here as a work group is address what we were charged to do. So what this page is getting at, thank you, Dee Dee. I apologize for not managing the thing on the wall. We want to make sure that we as a work group do what we were charged to do. And so what this page is, for those of you that aren't aware, it's not that we only count in odd numbers, 1, 3, 5. It's that when you look at the advisory council report, and are people familiar that our kind of existence as a work group stemmed from the advisory council. So, you know, before the work group process, there was an overall advisory council of, you know, hospital leaders, payer leaders, others, who set forth the principles and how to implement this new waiver. And they produced a report, which, as a result of Laura's suggestion, we will get it, as it was said, it's on the website, but we'll get that all emailed out to you, laid forth a number of guiding principles / recommendations. So what this page does is pulls out the ones that were most relevant to us. And so hopefully what will, you know, so that we can sort of keep in mind that this is our job. And so that our recommendation should address these. And I think it's worth just sort of highlighting them quickly. So the very first, and as I recall, and anyone jump in if my recollection is wrong, I think they were kind of structured, the recommendations in that advisory council report were intended to be structured in order of priority. As I recall, I think that was, I feel like I remember that as part of the discussion.
Yeah, not really. There were a series, they kind of lumped them in different categories. So they weren't necessarily in priority order, and but they did actually specifically in the report say the priority is to meet the, you know, to meet the 358, to meet the Medicare goals, and to meet the HAC and the readmission, those reductions that are specific in the contract. Obviously, that is the priority. Yeah. Beyond that, there are a lot of, you know, some ideas on ways to get there, but the absolute priority were those, and they were up front in the report.
Yeah,
you're right,
maybe I'm thinking about that because that is number 1.
Yeah,
I remember that being a priority, and as you can see, as we list, you know, sort of principles 1, 3, and 5, number 1 is exactly what Steve just said. So I think that was, you know, it was said that that is a priority. Number 3. Obviously related to us, we should play the role of regulator / catalyst / advocate to get the support needed. So, for example, to push through, you know, any gain sharing mechanisms that are needed. And I think this is a little different than, to some extent, the historical role of the HSCRC has been more in the regulator bucket, and, you know, and less of the catalyst / advocate bucket. And as we talk about the things that we're trying to do, I think this was a good example related to David's question, where, you know, in some of the areas we don't want to tell people what they have to do. We want to be a, you know, a catalyst to make it possible for them to do what they want to do. And then we want to be an advocate by saying, you know, here are some clinical opportunities we see are real opportunities. Go forth and do good things. But we're not going to regulate what they do. And then number 5 is obviously this gain sharing stuff, and that very specifically, it's our job to provide specific recommendations on strategies to align incentives. So, for example, to go to CMS and get the authority we need.
I have a question. This is Betsy. I thought the Advisory Council was going to also produce a report on what's happened in situations outside of Maryland where there's been failure. And I wonder if there was any information on difficulties with physician-hospital alignment.
There is a white paper being developed by Jack Meyer to look at some of the, it's mostly on global budget models outside the United States and some experience there. And I've seen an initial draft of that. So I think that's in the works. There will be something coming out at some point. Obviously, it's difficult to compare Maryland to other states in the nation, and sometimes difficult also nationally. But there will be a paper. I don't know the timing of that.
Okay.
I would say in the next month or so, we probably will see something. We'd be happy to share that with you when it comes out.
Great. Do you know if there's any focus on physician alignment in that paper?
There's a lot about care coordination, but not specifically on physician alignment that I've seen so far.
Thanks.
And just to build on that, since you talked about global budgets outside of the U.S., I wonder if they've looked at the VA at all. You know, VA operates on a global budget, so it's broken up by Veterans Integrated Service Network, so it's regionalized, but then monies go down at the hospital level. There's 152 hospitals in VHA, and they generally operate on a global budget, so certainly something to take a look at.
Just an observation. I think this Section 5.1 is written very carefully. Whoever wrote it put a lot of thought into it. It must be strong enough and occur early enough. So I think in order to make this all work, the physician engagement part, the population-based part, needs to happen up front. I have concern that some of the other things I hear, it sounds like the population part is being pushed into the later years.
No, that's a good question / comment, Dr. Wynn. We will definitely talk through today what we think is possible, and we'll get onto this in the very next page. It's funny, people ask questions, they constantly seem to be on the very next page. You know, what is allowable today versus what are we trying to enable? And so I do think we have to, you know, highlight what is allowable today, so people can get to work where they can. You know, so whether that's the non-Medicare market, where barriers don't exist, such as they exist in Medicare, whether it's pay-for-performance models, such as that Kim spoke about, or whether it's the AMS gain-sharing models, which are within the four walls of the hospital. Those are things that I think can be done today. You know, I mean, that'll be some of what we have to figure out. There are a number of things that can be done today. And I think we absolutely have to have a focus on them and not just be trying to enable things for the future. Is that consistent with what you were thinking?
Right. I think it's consistent with the philosophy here.
Yeah, absolutely.
Dr. Lowen?
Yeah. So I think it might have been number 6 in their council report, but there were other things in kind of thinking about truly engaging and getting physicians aligned with the waiver, not necessarily just with the hospitals, but there was, I believe there were comments about, you know, that the HSCRC is going to be an advocate, it should advocate for some of the outside things that affect the physician's ability to participate in some of these things, such as malpractice, and I think even, you know, Stark and stuff like that we've talked about here. And that was in the advisory council report. I can't remember the number. But I do think that if the HSCRC is going to take a role as an advocate and you really want to get physicians engaged in this process, seeing that it might actually, be an advocate for some of these other topics that are burdens and hurdles to participation would be helpful.
I will add, since session just ended on Monday, we actually did, we heeded the advice of the Advisory Council, and for the first time, we submitted letters on the malpractice bills, letters of support, letters of information, letters of concern in some cases regarding malpractice bills. None of them passed this year, good or bad, it depends on where you are. But I will say there's a provision in the legislation, House Bill 298, which is the bill that gives us the statutory language to meet the provisions of the contract. There was some uncodified language that was put in there that said that the work groups, a work group or the work groups, shall look at the impact that defensive medicine has, one, on hospital costs in general, but also on meeting the waiver requirements. So you will be, and we're looking at trying to potentially employ some independent folks to help us, because there can be some serious analysis around that, and because the literature's all over the place, as you know. So we're going to try to bring some folks in, some experts potentially, to try to address that issue. So that will be on, I think this is probably the appropriate work group to discuss that. So at some point, we'll have a report or some issues related to that.
And particularly as it relates to point number 5 in physician engagement, I was wondering whether it's part of this work group or the process as a whole where physician education is going to be part of this. I've been struck by, talking to docs in my hospital and community. They don't understand even what the waiver is. They don't understand why there's so much talk about and movement on the hospital side because of the waiver. So I think if physician engagement and alignment is essential, I think we need, somewhere in this process, we also need to have some way to communicate this in an effective way to the physicians of the state, because I think there are a lot of smart people around this table, but the docs just don't get it. And I don't think it's that they're incapable of getting it. I just don't think there's any avenue for this information to get through to to the physicians of the state. So.
Yeah, no, that's very helpful. And as we talk through, some of the things we'll talk about today include what things get done at the state. Where can the HFCRC be a catalyst advocate to help things happen at the statewide level, whether it's the legal stuff getting mechanisms approved or whether it's helping facilitate getting the data and building predictive models to identify high-cost patients. It's just creating a communication strategy. That's a really good example of something that, why not be efficient and let's all work on it together, as opposed to having everybody do it individually. Just more efficient.
And this is a new role with the Commission sees, and we're trying to address this. And it's not only physicians; it's consumers as well. I'm sure Betsy was about to chime in, but we agree that this is something, and the Advisory Council acknowledges this too, is that there needs to be more, transparency, education, particularly for consumers and physicians alike. So that's something we're going to struggle with because it's new to us. But any advice, that the work groups can provide and allowing us to do that. Keep in mind that we are small staff. We don't have unlimited resources to be able to be an advocacy unit for malpractice and things like that. But if there are things we can do with our existing resources, it's a priority for us.
Yeah, and I would highlight that, and any of the folks from MedCI feel free to jump in. I know that there have been substantial discussions with MedCI, with Jean in particular. Donna, I think, just recently went out and did a presentation to MedCI leadership. I mean, it takes time for this to work its way through the process, but I would like to think that the lines of communication are open. Jean was quick to ask Donna to come in and do a presentation to leadership, and I think it'll take time to blow this out and, to keep peeling the onion and drilling the message down and get the message out. But I do appreciate, and I hope, MedCai thinks that the lines of communication are open and that we'll work at it.
And I should add, Gene, we've talked to Gene about this, and we've had a strategy. For Donna's done several of these MedCai, and Dr. Lowenthal, I don't know if you attended all of them, but I think they've been really good. But the idea now is, now that the folks at MedCai, particularly Gene and some of his folks, have the slides and understand the process, is to proliferate, for them to proliferate from there, because we don't have, again, talk about resources, we can't talk to every single doc in the state, through every other day have a meeting with the MedCai group. But we would hope that also that MedCai and other organizations would go ahead and proliferate that information among the various physicians around the state.
Just as a quick comment to that, it's not easy all the time for MedCai to get to the employed physicians that are at hospitals. So if the hospitals can, help in that respect, they just oftentimes are not interested in being members. It's not always the easiest thing to do. So if hospitals can help in that sort of education, it's only going to help the whole process.
I think a lot. I know we have probably a core group of about 5 people at the Hospital Association. I feel like we're a speakers bureau, and we're speaking. We do several presentations a week on this as well, and have standard slides that we've made available to hospital leadership. But you're right, it's a massive communication issue with physicians. How do you communicate within your hospitals about what's going to change, those that you employ, you don't, in your community, how hospitals' role is changing. So I think it's really going to take a broad effort. Those standard slides, that plan, it's not going to be done in a couple of months, and engaging the community is something that MHA is doing with the American Hospital Association is a community conversation, and we're doing it in June. And these are happening in several places across the state. This one's going to be happening in the Annapolis area. And we've been given permission from the American Hospital Association to make it more Maryland specific. And it'll have American Hospital Association leadership talking about how things are changing, but then we get to talk with leaders of faith-based communities, business, providers, and others about the change that is happening. And the goal is to have people have enough of an understanding that they can inform us what else they need to then talk to their congregations, their employees, et cetera.
No, that's good, Dr. Zummel. I think you're definitely on the on the radar. Okay. I think anything else on page 3? I don't think so. On page 4, we tried to list what are some of the key questions for this work group. What are the goals / principles for alignment and engagement efforts, and that we'll get into very much on the next page. What's allowable today versus what changes are needed in laws to enable future models. That's the question that Dan Wynn just brought up a few moments ago, and I think we'll talk through that. That's clearly on the radar in terms of getting going with things that can get going, while at the same time being focused on enabling authority around population-based models. What specific alignment strategies should we pursue, and how? We talked about that a little. Not that we know that that's what we said will be the ultimate answer, but I think as Barry said, it's a good place to start, and we'll see where that we could start with that as an ask and see where it takes us. Talking about what things the HSCR does is a catalyst versus an advocate versus a regulator. We've talked about that a little. What strategy should be pursued collectively, such as what Dr. Zummel just brought up, or we've talked about predictive modeling. We can talk through other components of, there might be other components of care management that folks can collaborate on and do at the statewide level. I know I've talked to Dr. Herrera about some things that the state has looked at in terms of the SIM program that could be helpful in terms of driving things at the statewide level. Sort of this last question is similar. Where is it appropriate to pursue common versus expect different approaches? Although that's a little different. You know, one is collectively versus individually. The other is, you know, even if you're doing things individually, to what extent are people doing the same thing versus doing different things? And again, I think as you get into a lot of this care management stuff, obviously the HSCRC has an interest in people being successful and highlighting best practices. I think it'd be great if the industry worked together to highlight best practices. On the other hand, broad flexibility, you know, there should be opportunity. You know, I think different things will be needed in different areas, and flexibility. You know, we don't regulate how to do these things. So any comments related to these questions, or, you know, importantly, what key questions are we missing?
I don't mind starting.
Please.
The second bullet, what is allowable today and what changes in federal state authority are needed, and this was picked up on in a, maybe it was one of the recommendations about barriers that exist within Medicare. But I think there are barriers that exist within state law as well. And I would like to see the report really answer this question, because I think a clear recommendation where the state has a role as a regulator, as an advocate, are to address those barriers, seek waivers to the state issues. So we have a version of Maryland self-referral. What do we need to do about that? Are there other things that we would need to address to push various physician alignment strategies? So personally, I would like to see that answered in the report, and a clear recommendation for the HSCRC role.
There's actually, this year in the session, there might be some things that can help us to start. There was legislation that passed, and physicians probably know better than I do, that related to not between hospitals, but between payors and physicians about pay-for-performance or kind of game-sharing sort of arrangements. So, and that, as I understand it, did pass this year. So it talked about, you know, it needs to be based on quality, you know, certain quality measures that meet certain standards and things like that. So that could be a start anyway, you know, a baseline for us to start thinking about some of the issues that need to be addressed in state legislation relating to, you know, hospitals and physicians as well.
So just to build on Nicole's statement, maybe as part of this section in the report, we can include state legislation / regulations that enable A, B, and C, and then what things we would still want to see, because what's in this report could be the basis for new legislation for 2015. So if we list out, you know, even if you go back, you know, using even the patient-centered medical home, 2010 and 2012, the payer-provider sharing of information for care coordination, quality improvement initiatives, and then whatever passed this year, and then what still needs to change, and not only recommendations as part of this larger effort, but maybe concrete recommendations for 2015, because, you know, that language will have to start getting drafted in September. So.
I'd like to add to the key questions for the work group and probably the advisory council overall. This is a high-risk, high-reward, high-penalty for failure program with, again, a short window, 5 years, already clock ticking. How the efforts, programs, advice match up with the timeline of required reports. I believe the first one, according to the legislature, is due in October of this year. How that, the things that we're doing here actually align with the necessary reports and the pieces of the waiver that are granted. Because too many things, boiling the ocean won't get you to the end result in 5 years or even by October. So how whatever is done matches a timeline for success or failure.
I would share that, and I would talk in terms of alignment, not only discrete targets, whether it's disease states, locations, payer arrangements, are where we've seen things succeed nationally. It's when you try and do everything, you get nowhere. But also in terms of alignment, and going back to the legal and some of the barriers, where we're expecting the money to come from to fund the pools that will generate the changes of behavior, whether from patients, from providers, what have you, will have an impact based on what the laws are. I mean, right now, hospitals have limited ways to do it. Very formal gain sharing in certain ways, but there are a lot of prohibitions on that. Where the data is, having access to the data is going to be critical, because a lot of it's locked up at the payers versus the clinical data, and they're different and they don't match, and there's no great aggregator anywhere to actually figure out where to target even. And we're all sort of guessing based on what's worked elsewhere. We have no idea. There's no database we can mine, even at the state level, that says this is where all our healthcare spending went, and this is who the people or the populations or the areas we need to target. We're kind of trying to move very quickly in the dark, and not having that is going to make it much more difficult to meet the very challenging timelines. When you look at the program that succeeded, you know, North Carolina, a great Medicaid program for the certain disease states. It took them 6 years to get it off and running and to really see results. We're trying to do something in 6 months.
I think this is Betsy Carrier. Just following on that, I think the physicians will really play a critical role in terms of being advocates for patients during the switch to global payments, making sure that high-cost consumers are served with all these changes that are taking place.
Yeah, no, I think these are all good thoughts that can be incorporated to start. Obviously, you know, attention to the timeline and making sure we're doing things that match up to what we need to get done is something we should include. I think that the data piece, Scott, that you were talking about, I think that's something that we will talk about. It's also a place where we intersect with other work groups, but that I sort of mentioned it in passing before, but I think that is a very clear place where the HSCRC has the opportunity to play the role of catalyst / advocate to help, and has been very focused in working on getting the data from CMS to, you heard me reference before, predictive modeling, getting the data from CMS for the 770,000 Medicare beneficiaries in Maryland so that you can build a predictive model and identify who the high-cost patients are.
And this is Scott again. To follow up on what Betsy just said, she's right. Physicians are going to be critical, but particularly in the non-central parts of the state, we have a real issue with physician availability and physician shortage. And reimbursements in our base fee schedules from our commercial payers are a big part of that. And lack of bargaining power, and when you compare it to other states, recruiting new physicians in the states is incredibly challenging because of that. So that's something that also has to be factored. If you don't have the physicians, you're not going to be able to get at the front lines in the primary care world, especially, but in the ambulatory world and for specialists as well. They're too busy. They don't have to worry about being on the cutting edge and really participating in everything because they have as much volume as they need already, particularly in the rural areas.
Right. I wouldn't be surprised if we end up talking about what one can do to use. I know I've heard a lot of talk, and I'm very familiar with using sort of community-based extenders and nurses and nurse practitioners and pharmacists and social workers and mental health professionals, sort of a whole range of a comprehensive care management team to support high-risk patients. I think that's part of what I think Sim has envisioned some of that, and that's certainly something that in my prior experience I've been real involved with. I know there's good examples of where that works, and works especially well in rural areas.
I think it's Dan Wynn. If you're saying that you need strong financial incentives to get physicians' attention, to get them to participate, I think that's true. Otherwise, it's really difficult to change what they're doing. You really have to get their attention. So is that what you were saying?
That and the...
Not necessarily higher fee schedules, because we're talking about different type of arrangements. We're talking about shared savings, global payments, but at the end of the day, there has to be strong financial incentives.
Well, I'm actually saying both. Yeah, I agree with you. We need strong financial incentives, but particularly in the rural areas with the non-oligopolies, where you see standard fee schedules delivered 65–85% of Medicare for individual solo docs, there aren't enough doctors. And even the health systems that are employing doctors, if they're not part of one of the big three systems, aren't getting the same, anywhere near the same rates. So you end up with losses that are now being subsidized where money that could otherwise go into infrastructure to develop population health.
Right, I'm just trying to change the conversation a little bit. So away from fee schedules, because that's a small part of where the money goes. The money goes to non-physicians. It goes to other things. That's what we're talking about, right? Shared savings, not fee schedules, but a different financial model.
At the end of the day, we need to be able to compensate physicians enough to recruit new physicians to Maryland, given the amount of losses we're seeing. And right now, the economic model, however you want to shape it, and however we want to address it going forward, whether it's, I agree with you, it's probably not a fee-for-service model, but the dollars that are there in the pot have to be bigger for the non-oligopolies.
I'm sitting here sort of thinking in my own mind that I feel like it's one thing to provide flexibility to do gain sharing, shared savings with incremental dollars that are created, if you will. It's another thing, and this is getting back to the first report, the current payment models. I'm sort of sitting here thinking that another thing is you got to sort of break the basic fee-for-service incentive. So this sort of gets back to the presentation that Barry made. I'm sort of sitting here thinking that given how much money is available through shared savings, I think it can't just be about the incremental dollars, if you will. There has to be some sort of restructuring of what does one's base salary expect them to do. In other words, the salary shouldn't just be for RVUs. If you have a faculty practice plan at a health system, it's not going to just be the incremental shared savings dollars that get them to focus on population health if the bulk of their earnings are still driven by RVUs. That's sort of going through my mind. I'd be curious what people think about that.
This may be a little different twist on it, Rob, but it gets to, I think, what you're talking about. And
yes.
What's rolling around in my head is more of a question, and that's, and I don't know, Steve, you may be able to comment or not, but did the advisory council comment that the vision is that the hospital revenue stream is the way that we would potentially in perpetuity fund community-based care management activities? So I'll give just a little example of something we talk about. We could ramp up a house call program that we have today and say, rather than let's send our geriatricians or internists to nursing homes to try to prevent the admission when Mrs. X is going downhill. Let's get to her in the nursing home, see if we can keep her there. We're quite sure that the fee schedule wouldn't make that work, but we're pretty sure that we could fund that. And if we believe that we as a hospital could recover that cost through brain tumors and deliveries of babies and the other things that we do in perpetuity, we could fund that for a long time. If we believe that we can do that for a year, and then the volumes that we successfully held off then result in a reduction, it's not a long-term strategy, and that would have to get funded some other way. And so we're just interested in whether anybody has thought, does 7 years out is the success story that we are funding these really great care management concepts that we're talking about through the acute care hospital revenue stream? Or do we imagine a day when we've pulled those costs out of the hospitals and funded them some other way so that the cost of a brain tumor and delivering a baby doesn't include the cost of community-based activities? It's just sort of a broader vision question that might get at how we would align and fund these kinds of things going forward.
Well, at least with, let's just take Medicare as an example. We're like a big Medicare Advantage plan or a big ACO. So on the one hand, you're saying, do we fund them with the hospital revenue stream? But really the hospitals are like a big ACO or a big Medicare Advantage plan. And so to the extent that we create these shared savings models that bring in the non-hospital dollars, then you got total Medicare expenditures. That's what the revenue stream is. Now, a big piece of that is the hospital piece, and I think if you talk to a Medicare Advantage plan, they'll say, you know, when they invest in care management, the bulk of what they're using to fund, the reason why they're willing to invest in care management, the vast bulk of the savings they're looking to create is hospital savings. So under the global budgets, if you get rid of volume and you get to keep the money, you know, and you keep the money, then I think, yes, in a sense, it is funded off theoretically the hospital payment stream, but really it's like an insurance premium, plus you're pulling in some of the plus the idea is to use the shared savings authority to pull in some of the non-hospital savings as well. Is that?
It sounds like you're saying it is the vision that we, and I don't have a right or wrong answer to this. It's more just what are the powers that be thinking that this looks like in 7 years, that it is funded through that acute care revenue stream. That's an answer, and it could work. And there's another answer that says, no, let's not do that. Let's find a way to begin to segregate those funds for community-based things and not run those through the hospital revenue stream.
Yeah. I think there are multiple factors here. That is one strategy that I think, at least early on, that
has to be that way.
But I told Dr. Herrera about the press or green button there. But there are other things like the SIM project. Any funding and that initiative kind of rose in the same direction. Whatever money is behind that. You have the HEZs, which are also rowing in the same direction. There are other departmental initiatives. The SHIP program, which is providing data that we all can use, toward population, seeing how we're doing in terms of population, and that physicians could also use as well to help guide them, through the process. So this is probably, from the commission standpoint, what we have the authority to address. Yes, and I think presentation that Kim had earlier is an example of how that, how it works through this.
But I think long term.
We'll use your mic there.
Oh, I'm sorry. I think long term, one of the things when you put on there what legislative type of things do we have to change is that type of thing works for a while as you're taking your volumes down. It generates funding that you can use for it. But long term, as those volumes go down, you're going to end up having charges for those people who are using the services be extremely high, and that's where you get into taking and paying some of that money back. But then you have to have something that says the insurances are going to put money into the pool to be able to then do those gain sharing programs, because you can't let the hospital charges get so high for a delivery or a brain tumor or whatever. And but once you take it out, you have to make sure that those funds that are coming out that are currently being used to help drive that change, that the insurance companies don't say, oh, well, we're not going to pay for it.
So I think this is something that Rob, we should consider, as part of the report, that there could be a point of diminishing returns from this strategy. What happens then? Yeah. So
it could get distorted to the point where it didn't make sense. Probably early on, that's not going to happen, but you could imagine.
It's not that far off, though. I mean, we've run CPR now for 3+ years, and we're starting to see, we were the lowest cost hospital in the state for years and years and years, and part of the reason we went on CPR. That's creeping up, because as we're taking costs out and we're taking readmissions out, and we're doing a good job at pushing medical homes, we've got 98% of the primary care in one of the other medical home programs, and we're doing all these things. The cost of the individual patient is going up, volumes are going down in general, and we're starting to get pushback from the board going like, wait a minute, my charges are bearing no relation to what you're actually doing now. It's just how do you get to your revenue number, because we need that revenue to fund losses on the physician side and care coordination, transitional care programs, and all the other things that we're doing.
And the cost to the public is declining. I mean, the
growth
overall is
But for the individual
I understand.
patient who's getting that bill, they're looking at it and going, wait a minute, I had this same procedure, the same stay a year ago, 3 weeks ago, and it was 20% less.
Yeah, I don't know. Well, this is a definite good thing to talk about, but just my own thought is that usually these bills get paid for by not individually by the patient. It's an employer or it's an insurance company or Medicare, and I would think their position would be that my population-based costs are lower. I mean, I'm willing for the hospital. The hospital is now this global budgeted mechanism. It's not just a hospital anymore. So if it's investing in community health and driving down volume, which results in lower population-based costs and better quality and hits the triple aim, the hospital's like an insurance company. I mean, that's what it is in the new model. So at least that, if I was a payer, I'd be happy to pay for it.
This is Betsy Carrier. A question: just how do you make those same investments in more urban areas where there are going to be overlapping hospital systems, so they're not free to avoid free riders? That question makes sense?
That's a great question. I think, fortunately, that's on the payment model committee.
But it will certainly impact.
Good luck to them.
That'll impact the physician piece, because physicians will be more or less successful given the investment in needed community resources.
No, I think you've hit an excellent question, Betsy. I mean, to me, in my mind, that swirls around the hardest question in the implementation of this whole system. That's just my thoughts of this. Attribution, market share, good volume, bad volume. That's the hardest question in this whole thing. But it'll have to get figured out. But it's not for our committee to figure out. Dr. Panich?
In speaking back to the charges, what we see, at least in the emergency department population, especially with the increase in the high deductible health plans and the observation charges that are being floated down to the patient, those charges are actually very, very real to many, many people. And there's a lot of refusal of care or people leaving the emergency department when they understand how much the charges will be. So it's actually not quite, it doesn't float down to only the insurance companies and third-party payers. There's real people who are being affected who really are opting out of care because of charges that are floating to them. So it's a very real concern.
and still imagine if those people were in any other state, right? No, it's a real. I agree with you, but it does. But it does strike me that when you think about where charges are in Maryland compared to
200%, 300%
compared to the rest of the country.
Yeah, but we're not just talking about self-pay. We're talking about Medicare. The 20% copay on Part B charges for observation. In Maryland, our observation charges, at least for our hospital, is very similar. In fact, sometimes higher than an equivalent admission, because it actually does measure the amount of care. In the rest of the country, it's half or less, and they're hitting 20% of that. And everything Medicare is doing is pushing more and more people into observation. Right. So this issue of charges going up is hitting people in their pockets in our community today, and it is not a small issue.
I just echo that. Our ED director told me the other day he was actually told point blank by a patient, if you will not admit me, if you say observation, I'm walking out.
Wow.
So it's not an insignificant issue. And the only other one to think about, these are all, they're not the end-all, be-all, but they're just stories that help. And the other is some of us do compete for out-of-state business, and the extent to which our costs get higher for the brain tumor, the other things that we do, because we're funding what I'll call the public health system through the acute care hospital rates, we can distort our ability to compete for that work too. Again, it's not going to happen overnight. But these guys are giving examples that it happens over 3-4 years, so it's not immaterial.
And I apologize. I have to leave for an MHIP board meeting, but I want to make a couple points before I leave. One is, and Steve, you can speak for yourself, but I've heard several times through our commission, and I know we've been talking about financial incentives, toward reaching the goals. One was mentioned today about sharing data and infrastructure. I think, Scott, you had mentioned that. Also, because some of these financial ones are going to take, depending on what model you use, may take some time. Like if we need gain sharing authority, we got to get approval from CMS or the OIG, whoever it is, and we need to change our state laws. That's not going to happen right away. There are some things we can, there are things that can happen right away. But also, as part of this report, I think in addition to the financial incentives, there are a lot of other things that will make your life easier or make your life smooth the path toward alignment. In other words, smooth the path for care coordination and care transitions and things like that. I'm not saying today, but if you can think about those as well. Those are maybe some things we can do or we can encourage. I don't even know if we can do them. We might be able to encourage or at least put some in a report, whoever is the authority on that, that might be something that we can do early on. So, Steve, do you want to add anything to that? Did I characterize that correctly? Steve Jenks? Yeah.
I think it's close enough that I'm not sure there are any differences.
Okay. Yeah. Okay. And the other thing on recommendations, keep in mind you are making some recommendations, and this is how all the work groups have worked. Provide recommendations to staff, for advice, and then staff will, sift out what you've provided and see what may require recommendations to the commission, which could result in a recommendation to commission. There are other things that may not be commission related that may relate to the department or MHA or other folks that we can try to help encourage and push along. So there may be several buckets. There may be some things that you want to recommend that the commission needs to do. They need to change policy. Or there may be things that how the industry needs to change that we, in essence, don't have authority for. So think about some of those things. Yep. Barry.
I'm trying to react to some of the comments about the disconnect between what we're asking the hospitals to do and how the hospitals get paid. This isn't an immediate response that you can do in 6 months, but perhaps the problem is, and I think the term is paymaster, Kim would tell me better, but you have charges, right? 2,000 things you charge for. And perhaps the problem is we don't have enough categories of things that we're actually allowed to charge for, either Medicare or the commercial payers. If you could charge for discharge planning, case management, whatever that program you just called, home something or other, and it was on your paymaster, and you charged for it, and you guaranteed a result that, in fact, Rob, your overall utilization had a match, and the overall payment to the payer had to go down. Then you have another thing in your charge master that you're charging for, and it doesn't cause the brain surgery or the observation charge to go up, and they could regulate into a more normal pattern, because Charlie's right that this is a short-term issue for the hospitals can fund some of these, provided that their global budget doesn't go down after they show they don't really need the money. And the difference between this and an ACO is the payer shares the savings in an ACO. There's nothing in our global deal with CMS that if we save $440 million instead of $330 million, that CMS pays the extra 50 to us. In other words, we don't get that payment, but you do in an ACO model. That if you have the shared savings, the payer pays more. So I do think we can accomplish things short term, but I agree with Charlie that it breaks after a while, and if there isn't really shared payments. But I think perhaps we should be advocating for a different payment for something else, but you got to guarantee results. You can't just get paid for case management. In fact, if utilization doesn't come down.
In a sense, you're under a global budget, so you kind of have to hit the results. So that's a really, I think, Barry, that that's an interesting notion, that if you're going to invest in all these other activities, you kind of, that's how you're allocating. I mean, I'm not an accountant, but it sounds like a cost accounting thing, right? If you want to allocate some of the charges to those activities.
Yeah, because otherwise you do get into odd things, because it does. People really are walking out if you go to observation, and people from Saudi Arabia will stop coming to Hopkins if the brain surgery charges 4 times what it is at Cleveland Clinic.
Now, the policy currently, as I understand it, and I'd have to get advice from other staff, as I understand it, is that the advice has been, and I don't know if it's written in policy, but when the rates increase, that it has to be apportioned over all of the buckets, or maybe not all, but at least most of the buckets. There may be some exempt buckets.
There are corridors where you have to stay within a certain amount of your charge. You can't just dump everything into one area.
Right. And that gets into the all-payer aspect. If you dump it into OB, it differentially affects Medicaid.
For everybody to start, it's room and board is what his first room and board goes up. It's just, your lunch, it gets very expensive.
Yeah.
And that is
not anymore. It does have to go across all buckets. You can't choose to just raise your room and board, which you could before. Now, if you're making a change, you take it across all of them.
But Barry is right. I mean, basically what we almost need to do is reverse the 1979, 1980 law that keeps the HSCRC from hospitals' regulated funds being apportioned for doctors and outpatient clinics. Because right now, like when you're doing the disease-specific clinics, you're doing them for free. You're not charging anyone for it because you can't under the regulated system. You can't allocate those charges to your TPR or to your charge per case. So we almost kind of need to be able to extend the reach of the health system so they can partner with the physicians and the extenders to deal with it.
And I'm sorry, I'm a concrete chief operating officer, so I think what Barry was saying is for that home health example, to pay somebody to go to that nursing home and try to prevent Mrs. X from being admitted, one answer is find a way for the hospital to be able to bill for that intervention in a way that covers that cost, including the fact that she's got to be on call for 12 hours and may only get called once. So it could be actually an expensive little visit, but that's the truth of it when you do that math, and that's what I think I'm hearing you say.
And I think some of the ACOs are doing that. I think I'm trying to think if yours is. I think you're paying primary care docs,
right,
Howard, now to do things that nobody else pays them to do.
Right. It's sort of a simple concept. It's doing what is right
at the time that it needs to be done. Right. And Charlie, what you said was just crystal clear to everybody for a long time. If you can provide more care in a lower cost setting, particularly in the skilled nursing facilities, it's enormous savings to the system. And I just have to say, I share your concern about what the world's going to look like 7 years from now, what the success story is, because my crystal ball is totally foggy about what the payment system is going to be, 3 years from now. Is it, are we inexorably moving toward a global capitation, in which case the issue kind of goes away? Or do we still live in a world of mixed fee-for-service, capitation, global budgets, in which it's a Gordian knot that you just can't untie ever? I don't have those answers, but I think for right now, to meet the goals along the way, being able to say, just do what's right. It's going to save money and it's going to produce a good quality of care. That's what we should do, and that's what we'll be judged on. It's so frustrating to be mired. Healthcare is so complex, and you can get mired down in the details so easily and miss the big picture. So I think those kinds of things that you suggest and people have suggested around the table that are able to be implemented right now are the things we really need to focus on and put those on a timeline and say, okay, let's do it. Yeah. That's what we're going to be judged on.
Yep, no, I agree. And I really like Barry's suggestion as a way to jiggle the money.
We may want to look at what Oregon's doing with their Medicaid population. They set up coordinated care organizations, CCOs, not ACOs. That the organization, they're local based. So I was talking with the compliance officer last week who has the 12 most rural counties in Oregon, basically, and how to get physicians aligned and engaged. But it's global cap. This is their pot of money. They handle hospital. They handle behavioral health, which is a huge issue. They're going to be moving to handle dental. And it's Medicaid only, so they have control over it at the state level. We've got an all-payer system. Maybe we go that route.
No, that's certainly one of the things that these, as we move forward, we wanted to talk, that's back to the category we were talking about before of what makes sense to do at the state level, and that's a discussion for the HSCRC to be a catalyst and advocate, and others to decide, to sort of help decide. We want to facilitate the discussion and decide what makes sense to happen at a more global level. Okay, well that's very helpful. So can we? I think we're good to move on to the next page, the principles, which are on. Sorry, it's hard to see the page number on that page, but it's page 5.
Rob,
principles for discussion at the top. Yep.
I'm sorry. Before you, I wanted to raise another issue. In the last couple of days, if you're reading the New York Times or the Washington Post or the Baltimore Sun, you really can feel the impact that publicity can have on behavior. The last 2 days, we're seeing lists of docs and firehouses that get paid a whole lot of money. I do think the HSCRC is capable of collecting information. One that may give us some insight on some of the shortage issues that Scott mentioned, but also collect information that perhaps could change behavior. And that is, if the HSCRC asked all the hospitals, how many docs are on your salary, right? How many docs are employed? What are their specialties? Are you paying them on a RVU basis? Are you paying them on a salary basis? Don't tell us the names, but stick them in categories. Some of the more provocative questions would be, what is the ratio between the Part B revenue the doc is generating and his or her salary? And if you start getting at 120%, 90%, right, extraordinary numbers, the hospitals might be embarrassed and, in fact, start cranking some of those numbers down. Because if they're paying those kinds of high percentages, then the only reason you can afford to do that is those docs are pushing utilization. Something else is going on. They're using ancillaries. They're admitting patients. but nobody's paying 120% of their revenue just because they're pretty. I mean, there's got to be some other reason for it, and it might cause actually some of the ratios to go down. Medical loss ratios on the provider side really have an effect on the way insurance companies behave. A similar ratio between Part B payments and compensation for docs might have a similar relationship on what happens. And similarly, by knowing what specialties there are, you'll get a handle on the fact that, yeah, it makes sense that the rural hospitals are paying 120% because that's the only way they're getting anybody. And on the other hand, if you're paying 120% in a suburban area for a specialty of which you have 48 of them on your staff, right? Something else is going on, and it's not that. But I think the collection of the data, this is not one of your quick ones. In other words, you don't do this and it has an impact tomorrow. But over time, I think it could change behavior and give information. It could have the opposite effect. If you lower salaries, the docs will raise utilization because that's the only way they can make money. I'm not saying this is foolproof. There are often that you end up the opposite result. But I think the collection of the information would be useful in as non-threatening a way. I mean, you don't have to identify the doc's name, but by category, I think it would be useful. And it is something the HSCRC has the power to do.
Yeah, and I think that's in the zone of the issue that Steve Ports raised, that Dr. Jenks spoke about, the idea of data collection and some non-financial mechanisms to drive behavior. So that clearly will be one of the things that we talk about in the payment models component of the report. So thank you. Okay, the next page, page 5, Dee Dee, thanks. The principles for discussion. I think we can read through these relatively quickly, but I think it's worth a little time on this page. And also the page I sent around from Nicole is related to this page, but on the page 5, sort of the highest level, use alignment models that facilitate ability to advance the triple aim makes sense. With all models, target areas where improved quality, reduced cost, reduced health disparity are aligned. So there's the link between quality and cost. In my own experience, when you do that, it just so happens that you tend to reduce disparity because that's you're focusing on the areas that are lacking in quality. The next bullet starts to get at something that we've talked about today. Focus on the clinical areas with the most opportunity. That's come up in other meetings.
Can I ask a question about that?
Sure.
So there, was that specific to, were you thinking more pay for performance? Because when I think of gain sharing, I think of it cutting across all cases to really maximize opportunity. And I think that opportunity could vary by hospital. We really need the data, right, to show us where to prioritize. And that might happen naturally. That all might shake out, and it ends up being the same couple of areas. But when I think of gain sharing, I think of all cases, all service lines, and not specific, maybe not zeroing in perhaps as much as I saw on the next slide. So I don't know that we know where all of the low-hanging fruit is.
Yeah.
But maybe perhaps for pay for performance, we can say it's, we're going to look at PQIs, we're going to look at high utilizers, and then that's going to shake out. So just if you could clarify what you were thinking there.
No, you're absolutely right, and that it's hard to know what I was thinking when I wrote this, but that's why there's the bullet next below. So if you look to the very next bullet, focus on cross-cutting approaches such as patient-centered, et cetera, and then if you flip the page, you'll notice under case-based, the first column of the next page, just to glance at it quickly, I named some example clinical opportunities, cardiology, cardiac surgery, and then if I get to the bottom, it says all.
Yeah.
So it's sort of this combination of let's look for the big clinical areas, whether it's diabetes, heart failure, CHF, COPD, and at the same time, let's also consider where there are cross-cutting approaches that hit all DRGs, such as gain sharing. So again, I'm trying my best to serve as in the role of catalyst. I don't know the answer to exactly where these things are, but that's the discussion that thankfully you're already having, and we're just trying to help the discussion remain open, to focus on sort of those, where's the opportunity?
Sure. So to tie it back to the principles that I kind of was thinking about yesterday, I think then if I look at what you've outlined, number 1 and 2, and if we even go back to focus on the waiver, how do you get, how are you focusing on 358? How are you focusing on 330 million? That to me is up here, and then hospitals have the ability to then figure out where that opportunity is and where they want to prioritize. And that's what I meant when I talk about the arrangement should be based on quality improvement consistent with the waiver. So up here, prioritizing where the advisory committee told us to focus, but then have flexibility to kind of go down further and say these are our priorities, this is how we want to do it in a local area where reasons for utilization vary, where resources vary, where culture is different, things like that.
Yeah, where you have certain service lines, where you don't have certain service lines, where the percentage of Medicare patients in one hospital is very different from in one hospital, where you have open heart surgery, you don't have open. It's absolutely, I can think of lots of reasons why the opportunity is going to be different in different places, and that's going to be the job. And we've talked about using, so you're absolutely, I completely agree.
So
David?
I have a general question about the idea of gain sharing. I think it's great. I like what Nicole has put forth, but I just started to wonder about the complexity of potentially 46 hospitals having somewhat or drastically different gain sharing programs. Could that create challenges for us in terms of monitoring, measuring, evaluating? And then likewise, does it have an unintended consequences of sort of drawing physicians into hospital settings where there are more attractive gain-sharing models, and then we create this dichotomy of competition that we never really thought would come from something like this? And that's a question for the group.
Yeah, Nicole, you look like you were about to respond.
Well, I will defer to others before I offer what I can have an opinion on. Anyone else?
Well, this is Dr. Paravemba. I'm on the phone. As a physician, that competition, I believe, would be looked upon favorably. I mean, we want gain-sharing mechanisms to be set up in hospitals that really promote incentives for us to provide more population and value-based health, and to design those programs. So I think one of the kind of checks and balances will be that there are appropriate mechanisms set up in hospitals that really promote that type of care. So some of that kind of that difference I think will actually be favorable.
But I think David is pointing out the complexity issue. Are there things that statewide we can classify as the basic principles or mechanisms and then allow hospitals to vary? I think I share David's concern that if you just let everyone do what they think is gain sharing even, that may create problems down the line in terms of creating these coordination between hospitals, because one issue raised is about the urban areas, how you're going to get the hospitals to cooperate and focus on the population that they're serving collectively. And I worry if you have this, design your wild, I feel you need some kind of ground level that everyone agrees that this is what is termed the gain sharing program, and these are the things that you do and then vary.
I think Nicole's suggestions are pretty good, the ones that she emailed in guiding principles. I mean, the only thing that I would add would be I like the idea of also a guiding principle having a physician, a steering committee in these entities that has a high physician representation as well.
Absolutely. So I think if we look at the New Jersey model with AMS, I think it's a good example. I don't think we would have 46 gain-sharing programs. I think we would have one with a certain number of hospitals that want to participate. There would be the ground level, or maybe two, but there would be smaller numbers that you would have that standard agreement. But then underneath, because you have steering committees at every hospital made up with majority physician composition, then you determine, what your real priorities are around quality, how you're going to align those incentives. I think we heard during the negotiation process with the waiver, if you want to do gain sharing, look to New Jersey. That was a direct quote from the Fed. So I think we would be wise to structure a program similar to that.
Yeah, and I think that's all right, and we'll can follow up with the folks from AMS that are here. I think we're sort of saying two different things, that enabling different hospitals to focus on different things doesn't mean that the model changes. In other words, you have one model. It's just when you're doing the education in the hospital, you're spending your time talking to the cardiac surgeons and the nurses that work with the cardiac surgeons and developing care processes and pathways and discharge planning for these types of patients, or are you doing it for those types of patients? But there could be some core parts of the model itself. It's not that the model is changing. It's more that your priorities of where you're focusing on change.
They had rest in one area and then, a discharge somewhere within 24 hours. I mean, there's things you could do that I think get to a lot of the core things that you put in your document that all move us in the same direction.
The other thing to keep in mind is gain sharing is not new. I mean, they're very, and Barrett can speak this probably better than I can in terms of, they're very clear federal laws on how to use gain share programs. And they've been existing in this state for a while, and we've done a couple. The problem with the ones that historically have been is that they have very short windows because you can't keep repaying for the same savings on an annual basis. So you see these management service agreements in hospitals all over the place. I would be surprised if we didn't have 50 different ones going on in the last 5 years already with different hospitals, and every hospital is different. They know where they're inefficient compared to their peers, and quite frankly, the HSCRC knows it too. They can see the costs.
Maybe the HSCRC can be someone that facilitates, if different programs are in different hospitals, that there's a lot of sharing of those programs, and the better programs actually are highlighted so that there's an uptake from one hospital to the next of actually successful programs as well.
Okay. Barry?
I think it would be helpful if the report had a section with definitions too. Gain sharing and shared savings are different, but different people may not automatically agree to that. They're also just payments to do things. So, I think part of the Western Maryland program, I don't remember now exactly, one of the programs that was presented to us, just pay doctors to do something. And it wasn't it wasn't sharing of any savings. There was no annual calculation, and it wasn't paying docs to use a different implant that would save money, but it would be just as good, which is gain sharing.
Which ties back into which actually ties into your suggestion before about expanding.
I just think it helps if we would actually. What we're encouraging isn't one thing, but there are multiple things, and I think of some vocabulary section would be good. On principles. One principle, I don't think it was in the MHA piece, but I think we have to decide, are we going to stick with principles that are very at a high level like the MHA piece, or are we going to go down to any level? One I thought about is independent medical review of the arrangement, both prior to and during the arrangement, to make sure patients are receiving appropriate care. There is some concern that what you're paying for is for people not to get care. And so is it something that the HSCRC should be saying there really ought to be an independent physician review prior, during, and after? And isn't that a principle that's worth articulating? Another one you sometimes see, which two speakers have already gone pro and con. David has said one side, and the doc from First Colony went the other way, was should the arrangement only be offered to existing members of the medical staff, so that you're not getting people to join you just for that. You can go either way on it, but that is another one of those sort of principles you sometimes see, and we could come out one way or the other on that subject. I guess you could be silent, and then you really are coming out one way or the other.
Right. Although if where we landed about it being a common approach, well, I don't know. It's a good question.
I like Barry's concept because I agree that I just worry a little about if we say before, during, and after, we could pay more people to watch what's going on and to actually do the work. And I know that wasn't your intent, but I think there, as a principle, to make sure that we have some safeguards in place to assure that we're not inappropriately doing that. I think what I'm hearing you say, that maybe I'm taking it up a higher level than that.
I think it's worth floating out there. We could end up at different places on it, but I think it's an issue that we ought to consider.
And I think the white papers, at least MHA's and Hopkins, they're written by the same person, talked about that to an extent. It talked about quality can't decline. So again, it's a little broader. It's bringing it up a level. Incentives don't flow if quality is declining in any way. And I don't know if maybe that's too high for what you're trying to get at. I tend to think principles should be higher level, and then when we actually sit down and write an application, that's when we get more into the detail personally. And I think some of these could get into a little bit about structure, not even just beyond structure, but up to operations. I don't know if this group should go that far. I don't know if that's really what you're trying to accomplish in the next few weeks before your report is due to the commission. It's a question.
One way to go along with what Rob was saying at the beginning of the meeting and also be the easy button is the ACO program for Medicare has very clear rules on structure, in terms of physician compensation on a governing committee, in terms of the mandatory compliance program, in terms of what you measure and how you measure and what type of participation is required to ensure that it's not just paying for volume. Now, our model TPR or GBR, as we move into it, sort of cuts against those motivations here, but it still exists, certainly. So I would certainly look as a principle that we model on what's already been approved by the FTC, the OIG, CMS, and not try and reinvent the wheel.
I agree.
I'm sorry. Notice to patients is also, again, depending on the kind of model. Some of them it won't make any sense, but some of them it would make some sense that you are actually in a gain-sharing model. Again, the notion of don't use this implant, but use that implant. There may be some that there ought to be notice to patients that they're being impacted.
Mm-hmm. Okay. So just as we're starting to get, we have more time, I just want to make sure we hit some of these points. I feel like, so we were just moving down on page 5, and I feel like when we get to we talked about the first 4 bullets, I feel like a couple of these sub-bullets, this 5th bullet is meaty, if you will. It has some key points. We've talked about them today, but I think it's just worth mentioning them, that I think these are some of the key principles that prioritize efforts while maintaining a vision for a population health approach. So on the one hand, and it's the 2 sub-bullets below are directly related to that. Okay, go ahead.
Yeah, I just wanted to back up to the 4th bullet for a minute, because Barry earlier mentioned a paymaster to include discharge planning, care coordination.
Mm-hmm.
So I think that speaks to the value of discharge planning, and what we see right now is that usually discharges are sort of a surprise that, oh, yep, you can go home. And as representing occupational therapy and physical therapy, I think that there's a key role there for discharge planning, that it's more than just can you walk 50 feet. And there are a lot of cognitive considerations. And it's, I think because the discharge planning isn't sometimes addressed, that then we get the readmission. And I know last week one of the speakers mentioned that people don't want to go to the SNF they want to go home. And then if they go home, is that the best place? And it was mentioned today that if they're in a SNF, then that's cheaper than the hospital. But the home is cheaper than the SNF. It's cheaper than the hospital. And do we really need joint replacements going to a SNF when they can go home? So I think just looking at that cross-cutting, that really overlaps with all of the rehab services with discharge planning, medication management, care transitions coordination. So if we put more value on that, then I think that will, whatever we pay, whether it's a direct paymaster or whether it's just how the hospital divvies the roles, that's going to be important.
Good. Thank you.
Rob, one of the things I've said to you, and I would be interested in others' reactions to this, is this historical separation of the somatic and the mental health and now substance abuse. In a medical floor in most hospitals, if you go and look, I better be careful. In the hospitals that I know of, 40 to 60% of the patients will have a comorbid substance abuse or mental health issue going on. And yet, historically, we've decided to segregate the payment models for those things. And so while everybody on the care team may know that this patient here today, for her 4th admission for diabetes complication, that it's blood sugar today, but the real issue is her underlying anxiety disorder that disallows her from appropriately following the plan of care that's going to keep her out of the hospital. Under Barry's view, there's no way for us to get somebody involved and get started on that plan of care. We're out of network for that. And so if one of the principles, I'd love to see one of the principles be to recognize that behavioral issues very often dictate utilization of non-behavioral health care services and encourage, where possible, interventions that would reduce that. It feels like a maybe too motherhood and apple pie, but I think it's so real to people who practice medicine every day.
I don't know if that would be a guiding principle or something that would just evolve in the processes that develop in the hospital. In the steering committee, that behavioral health may come up there as an issue among the emergency room physicians when they're admitting, and they may develop a model to try to address those situations more appropriately before admission.
If I can echo on that, I would totally agree that so many of the admitted patients that we see in the emergency department end up becoming admitted because of behavioral issues. And if at the front door of the hospital you could dedicate resources and have also a paymaster kind of situation where you can get a case manager specifically for behavioral issues or something like that to tackle those situations. Because in a comment back to the defense of medicine, very often a lot of treatment decisions made are not necessarily defensive, but because there isn't another solution. And so if we can, it's really to, if there's no other option available, you have to do choice A. And if we could tackle that particular issue, there would never been resources dedicated towards the behavioral issues of patients when they first hit the door of the hospital.
Yeah, I agree with you 100% on that also, just like the nursing home versus admission issue. It's another one of those things that we all have known for a long time. That's where the impact occurs. But the resources have not been applied there. And I think by principle, if we say, again, at a high level, if we do the things that are right for the care for the population, that we're not going to be wrong in the long term.
Okay, thank you. So I think I was just starting to say I think some of these next couple bullets are big. I don't think they're anything we haven't talked about in a sense, but I said prioritize efforts while maintaining vision for population health, and to drill down on that a level. The first bullet, continuum of models possible with goal to move towards population health. This sort of refers to the next page, this continuum of models. You know, Kate, I'm sorry, Laura.
I'm sorry, before we go on, I just wanted to piggyback on what Charlie was saying, back to what we were saying on legislation and what is allowable today, changes in federal and state authority needed. And I know much of that was around payment, but to his concern about behavioral health and somatic care being separated, there's going to be legislation and regulatory changes that will be needed around information sharing. And so for that piece of it, separate from the payer-provider piece that has been arguably addressed in 2012 legislation, but to put that on the
that's
list.
helpful. Thank you. So I just think as a general framework, again, I don't think this is controversial or anything we haven't talked about. It's just, I mean, the way I think about what we're looking at in terms of looking for the ability to create incentives with physicians, it's you have this continuum of case-based, episode-based, and population-based. Oh, okay. Dee I haven't had to do that. Yeah. That's it, because I was just going to go here for a minute and then go right back. I was just sort of saying that this bullet on slide 5 sort of refers to what I'm just to sort of get a picture of what I was thinking. You can look to page 6, and I think we want the report to make it clear that we want to get authority for hospitals to implement versions of all of these models, because different physicians in different situations require different things based on span of control. The one physician's span of control is more within the walls of the hospital. Another physician's span of control may be over an episode, whereas another physician's control may be more population-based. I mean, you can think of, the hospital-based physicians versus a cardiologist who controls an episode, or surgical episodes versus a primary care physician, or population-based primary care. There's some specialties, endocrinologists that manage people with diabetes, and nephrologists that manage people with ESRD. So you could use different approaches for different situations, and I think we want to provide opportunity to address all those situations.
I just want to reiterate what I said last time, too, just to make sure, especially on the case-based gain-sharing model, that they're for high-value services. We don't want to promote gain-sharing incentives for services that we want to be steering away from.
Yeah.
I'm not sure the definition of high value. One of the things we've talked about in the past and haven't been able to do because of the current legal structure is partnering with our hospital, with our facility-based providers, anesthesia, hospitalists, whatever, in terms of gain sharing, the savings, because while they're not high dollar, they have a huge impact, not on an individual base, but across the continuum. And our ability to partner and share with them has been limited. There, but limited. And so that, in terms of the current gain sharing program, so I would definitely want to make sure that we develop some standardized, clean pathways for hospitals to use with their facility-based physicians, particularly those that have outside groups.
Sorry. So I think, just, and I mentioned that the last time, the different medical societies are all coming forward with procedures that have little impact on the management of the patient or long-term morbidity and mortality related to whatever that intervention is based on whatever the diagnosis is. And yet these procedures have persisted despite having little additional impact on morbidity and mortality. And so now these medical societies are coming forward saying, consider not doing the following, or at least engaging in discussions with your patients about why that particular procedure may not be the best procedure for X diagnosis. And so I would just want to make sure, especially since at least the specialties that are listed here, and I know they're only examples, some of them use very expensive procedures that have not been in the evidence to bear out changes in morbidity and mortality. Good.
Thank you. And then I think so I was talking about the continuum of models, and these again are sort of two bullets that go together, and I think we can't say it strongly enough. Dan said it before. It's something we've talked about internally. I'm looking at Alice, who was concerned about this yesterday. Sort of the need to, on the one hand, we want to provide flexibility and have a vision for models that encourage population health, such as getting authority to do shared savings over time for populations. At the same time, we need to get going, and we need to really look at what can we do today, such as the AMS gain sharing model, such as things in the non-Medicare population could be an example where rules aren't prohibiting you, where I'm sure Dr. Heft, you're doing lots of things, or the ACOs that have the authority built in to what they're doing. So I think that's we need to keep those things really go hand in hand, have a vision of where we're trying to go, but at the same time really getting going with the things that can be done today. And I think a good example of one that we could serve as a catalyst facilitator for is, Nicole and others mentioned before, gain sharing a la New Jersey. That would be a good example of something that we could push forward more quickly. A few other principles on this page, some of them just to highlight. We've talked about them before. I think of leveraging current assets in the system, encouraging collaboration and shared infrastructure is, we've talked about whether it's the predictive modeling, whether it's education, whether it's the things Scott talked about before in Oregon. I know that's something that Don has raised and been on Donna's mind. And again, that's not an area where we're not going to have that much time in this room, and I don't know that it's our position to get into the details of that discussion. But I think outside of this room, whether through, with MedCI and the MHA, I think, and others, that's very much a discussion we'd like to help facilitate and continue offline is, what are the things we look to do at the statewide level. I mean, we'll make references in the report, and in my mind, that the report is the beginning, not the end. It's then how do we go on and implement those recommendations. So maybe we'll have more time to talk about them in a group after the report is done, or they'll take on life of their own outside of this group, but many of us will be involved in that. On the next page, page 6, I don't think we need to talk about this page because I don't think we now need to figure out where our priorities are. But my reasoning for doing this page was just to create a picture of why it's necessary to have, thanks, Dee, why it's necessary to have all the different models and to give good examples of why different clinical categories demand, require, would want different gain sharing approaches. And at the same time to highlight what some of the, not that we're going to get into them and discuss the priorities, but I thought it would be good to highlight in my experience and others, that which I've heard around the room and in other meetings, what are some of the high opportunity areas. So this is meant to highlight some of those. We don't need to necessarily talk about them. Although if anybody, if there's something missing anything someone wants to mention, I'd be happy to take it. Because this type of thing can be in the report.
Well, just, I see in parentheses there the episode base, the BPCI outside Maryland. And I know you had said at some point that this change in the waiver might put us in line to make that possible. But I think having something in the report that clarifies with CMS that now is something that we can apply for in Maryland would be beneficial for any, that tends to be something that a physician group that we don't necessarily talk about here very much, and some of the specialists that are not hospital-based may be able to take advantage of and kind of align with the overall.
Absolutely. So to go back to what I said at the beginning of the meeting, sort of the vision is to use the broad waiver authority that was published related to ACOs, but makes reference to other CMMI demos, to categorize ourselves as one of those CMMI demos, use that to put in place a series of waivers that enables us to implement various gain-sharing mechanisms, and BPCI, a Maryland version of BPCI would be among them. That's the general concept. So absolutely, it would be named specifically as one of the things we want.
And I think CMS is looking for as specific as possible in those areas. So really, once we decide which direction we're going, we need to put the meat on the bone and give them concrete principles, concrete programs, so they can waive it. Otherwise, I don't think they are looking for very specific information. That's my understanding.
Yeah.
Rob, it's Shannon. So as I'm looking at this, one of the things that's very striking to me is that the example tactics are very, very much broad-based in regard to who would provide those services. So I think that's something we need to be purposeful about in our report, is how we're going to leverage all types of providers in accomplishing these. Because medication management, palliative care, caregiver education, prevention, family education, those are things that, while I would say most physicians probably would enjoy having time to do and being incentivized to do, aren't necessarily things that they are doing now. But there are nurses, pharmacists, physical therapists, occupational therapists, and how do we leverage them and incentivize them to do those activities that they're now not incentivized to do.
Could I just ask just a clarifying question? Please. Maybe I'm the only one who doesn't understand this. At the end of the day, Medicare is measuring us on hospital measures or the per capita cost of a Medicare member overall?
Number two.
Number two.
Right?
No.
Wait, the per capita cost?
The first 5 years is per capita hospital cost that we need to save $330 million. And then we have a guardrail, if you will, to watch the total cost per beneficiary and don't exceed the national trend by a certain percentage. In the second 5 year is then the measure is going to be a total cost, including all the providers.
How do you know that? There's no deal for the second 5 years.
Yeah, we are going to propose. Well, but that's the thing. They are asking us to propose, and they are, they are not going to. They may or they. The plan, the proposal is 5 years hospital cost. For the second 5 years, we're going to come up with a proposal to ask them for total cost per beneficiary.
Okay, but that was my question. At the end of the day, that's where they're headed.
No. Okay, I misheard you. You said hospital cost, and I think in the second time you said per capita. It's per capita hospital costs. So that's the way I was thinking about it. So for now, it's per capita hospital costs.
Right, but I also heard the direction you think will be down the road is actually per a member, a participant, whatever the right term is.
Per beneficiary for Medicare total cost, and it's in the application we're saying we are going to apply on the end of 4 years. Where we need to come up with a plan to have the total cost of care measure. Whether they approve or not, what includes in there, is probably going to be determined later. But it's not my thinking. It's in the contract. We're saying we're going to, on the 4th year, we're coming up with a total cost of measure program.
I have a clarifying question also to follow Dr. Wynn's. And in the gain-sharing program, do things like reducing supply costs contribute in any way to Medicare's $330 million in savings?
Absolutely, because it reduces hospital charges. Absolutely. Good. Yeah. Which is why if we start with the things we can do today, such as the gain-sharing model, it will help get us cross-cutting across all types of cases in the hospital. It'll help get us towards where we need to be.
I'm not sure, Rob. Isn't it a little more indirect than that? If expenses go down at the hospital level, then the hospitals can live with a lower update.
Yeah.
And if they live with a lower update, then the cost to Medicare goes down. It's a little more indirect than I think as you answered. So, if you can bring physician losses down, if you can bring expenses down at the hospital with physician help, then the hospitals can live with lower updates. So the global budgets will be less high, and therefore Medicare will be charged less.
Yeah, no, that's well said. That because you're reducing your costs, you can live with less updates in the global budgets. Because they bring their charges down, they can raise their charge masters to hit the global budget. So it's not like the money goes away if the supply cost goes away. It just makes it easier to live with the lower budget.
It may be more of a payment model discussion. There is the other way it can benefit more directly is if you're talking about a procedure that Medicare is the predominant payer for.
Right.
So to take it another lever you could pull that you'd have to think carefully about is if you charged less for joint replacements and cataracts and charge more for the delivery of babies, you've saved Medicare money and everybody's neutral. And so there are more direct impacts. Cardiac surgery, orthopedics will likely benefit Medicare more immediately, to Barry's point. But I think you're exactly right. In the big picture, the hospitals will up their charges in other areas when they save that money, but the update factors would have to be less.
Okay. Just because it's 10 o'clock, so I want to respect our time. If you go to the last page, I've scanned down it, and I think other than the very last bullet, we've really talked through the other bullets today, and I think they're somewhat self-explanatory. We can say if people have questions, but I do think we've said that everything up through the last bullet are the things we're thinking about, and I just would like to continue to highlight it. We haven't said anything much about the last bullet today, but I think the more we get into this process, the more we realize that the work groups need to be coordinated. So I did want to highlight that, and this just highlights some of the places to look for interaction. One thing that has come up, the first sub bullet with the payments model, Dr. Jenks had raised this. That because of the global budgets and the level of revenues allowed under the global budgets, it's a reduction on a population basis for where we've been in the past. So we just need to be cognizant that sort of some of the first dollars of savings, in a sense, are necessary to maintain the ability to get to global budgets, so that we do to be able to create dollars for shared savings, that you got to get past the fact that you got to start by getting, keeping within this 3.58% cap. So I think that's worth pointing out. And there will continue to be, and then just also that a lot of need to interact with the other work groups. We've talked about some things related to the data and infrastructure work group around predictive modeling and data requirements. Scott, you've mentioned that. And then another thing that came up last week, another place of interaction, is alignment with the performance measurement work group. That is, as people start to identify what are the high opportunity areas and where people are going to focus on generating savings, where are clinical opportunities, it would seem that that's a logical point of interaction for the performance measurement work group, because they probably want to measure some of the things on which we're focused. So,
Rob, one question. I'm sorry. Could you just, for the second to last bullet there, what are your preliminary thoughts about HSERC's role with respect to care management at a statewide, regional, local level?
To facilitate a discussion.
Okay.
To make sure it's being discussed. We've talked to Laura about it. We've talked to you about it. I'm not sure that I want to. I'm not sure that I have any strong preconceived notions. I think Donna has certainly raised this as an issue. One that has come up continually that I do think is a great place to start is on the data side. So getting, for example, the Medicare fee-for-service data. Folks have talked about parking it at CRISP, for example, because that's a place where you all work. Having them use, there's many, myself, others have experience with using the Medicare data to build predictive models, overlaying proprietary software to drill down a level further, and use that to identify, high-risk patients, and then that data can be spliced out and pushed out, based on what markets they're in. But it would just seem, the HSCRC has the ability to get the data, and it would seem silly to chop it up and send it out before the predictive modeling is done. And from there, it may be we talked about education today. We've talked about some community-based care management assets, but I think I would really look to facilitating offline discussions, and our interest is, Shuley, please jump in, but I think our interest is to really make sure those discussions are happening and moving quickly.
And also, I think we all agree that there is some level of coordination that needs to be done, and also curb the over-experimenting, because care coordination, care management, although it's a difficult task, there are models out there that are already proven to be working. And I think if we can coordinate to find out those models that are working best, and then help hospitals to choose whatever is best for their needs, we would benefit, rather than every hospital trying to go in and evaluate all these models out there and come up with their own plan. If you remember, David Blumenthal's comment in one of the first advisory council meeting was, this is a big innovation that you're doing, but you shouldn't just go out and, I can't remember exact words you said. Maybe Alice, can you help me?
I think it was, this may not be the time to let 1,000 flowers bloom. This might be the time to focus on some trees and some strategies and some things we know that in the short time we have, we don't want to start from scratch and learn from the beginning.
So it was about the blooming flowers and the trees. Right.
But
right.
the point was, innovation is a long-term strategy, and we have a short-term time.
Right.
And it's kind of balancing.
Right. So balancing exactly the short-term needs and need to act quickly versus the innovation that we need and so HSCRC would try to coordinate those efforts and try to see if there are things that we can do directly or help others do to make it statewide or regional.
Well, that's a theme that's come up more than once today. Okay, good. Anything else before we adjourn? I think thank you for a good discussion. I think we're in a good place to try and put pen to paper and get stuff out for people to react to. Thanks.